Welcome everyone to our session, Gaps in Current Clinical Care. During this session, we'll be discussing the clinical care and our project, the Standard of Care Project, in which I had the honor of serving as project manager. I want to welcome several of our domain experts who will later lead a panel discussion. They are Dr. Gerald Pfeffer, Assistant Professor of Clinical Neurosciences at the University of Calgary, Dr. Bhaskar, Assistant Professor in Neurology, Yale School of Medicine, Dr. Nupur Ghoshal, Associate Professor in Neurology at Washington University School of Medicine in St. Louis, and Meredith James, Research Physiotherapist, John Walton Muscular Dystrophy Center, Research Center. To give you a little background, this project started with feedback from our patients. Our team was made aware of gaps in current clinical care, including long time for proper diagnosis, unclear screening guidelines for the different phenotypes of the disease, and common symptoms reported by patients, but not currently being addressed in their clinical visits. Cure VCP disease and our medical advisors recognize this unmet need and the huge disparities between clinical care and institutions. Together, we recruited over 50 clinicians from multiple disciplines and countries to participate in the project. I wanted to point out that these clinicians each volunteered their time to collaborate. This project shows the dedication that the clinical community has for our VCP patients. Thank you so much to each of you. Right now, Dr. Manisha Korb, Assistant Professor of Neurology at UCI, she served as the project leader and lead author of a manuscript that is it's in the review period to be published. She has prepared a summary presentation of our findings. And when that is complete, we're going to have a panel discussion with some of these leaders that are present today.
Hi, everyone. Thanks so much for joining us today. My name is Dr. Manisha Korb. I'm a neuromuscular specialist at the University of California in Irvine. And today I'll be talking to you about development of a standard of care for patients with VCP-associated multisystem proteinopathy. Today's topic is about how we established a project to go over the recommendations for standard of care for treatment and diagnosis of VCP. VCP-MSP is a rare, heterogeneous autosomal dominant disorder. It can cause various different organ system involvement, including inclusion body myopathy, IBM, Paget's disease of the bone, PDB, frontotemporal dementia, FTD, and several other organ systems. And this diagram on the bottom here shows some of those different organ systems that can be involved and their manifestations in terms of frequency. The gap in clinical care here that we recognized was that this disease is not well recognized by community neurology settings and even academic neurology settings. And because of that, there can be delays in time to diagnosis. There are no current guidelines on how to diagnose and care for these patients. And because of that, there may be a delay in how long it takes for these patients to be referred to specialists who may be necessary for their care. Aside from prolonged time to treatment, they also may have a delay in recognizing involvement of other organ systems. There may be disparate care between different clinics and different geographic settings. And they may also have developments of different diseases, not only in themselves, but also in undiagnosed family members that may go unrecognized as well. Because of that, we recognize the need for the standard of care recommendations for VCP-MSP. In order to undertake this project, Cure VCP convened a team of over 50 physicians and therapists of many different specialties, and we formed different domains based on which organ systems were involved. We had the different domains review the literature, exchange ideas with different meetings and discussion. We initially had a meeting virtually in December of 2020. After that, we were able to break up into our working teams or our domains and come up with written segments for each of the domains, which overviewed the clinical features, diagnosis, surveillance, and management strategies for these patients. From there, we had our meeting in April of 2021, and afterwards we were able to integrate all of our discussion into a manuscript, and that is currently undergoing submission to a journal. And the manuscript goes over all of the different domain recommendations. The domains include genetic diagnosis, myopathy, frontotemporal dementia, Paget's disease of the bone, ALS and Charcot-Marie-Tooth neuropathy, Parkinson's disease, cardiomyopathy, respiratory dysfunction, supportive therapies, including physical and occupational therapy, PTOT, and speech-language pathology, or speech therapy. It also included mental health, supplements, and nutrition. Our ultimate aim was to increase awareness of VCP MSP and improve time to accurate diagnosis, as well as appropriate and optimal standards of care for drug therapies and supportive therapies. Starting with the genetics domain, we determined that genetic testing is the gold standard for diagnosis of VCP MSP, as well as other genetic causes of MSP. There are several other genes that have been identified to cause a very clinically similar and also pathophysiologically similar type of disease as VCP MSP. VCP comprises about half of all MSP, but other genes that are associated include HNRNP A2B1 and A1, sequestosome 1, matron 3, TIA1, optineurin, annexin 11, and profilin 1. All of these different gene mutations can cause, or most of them can cause dysfunction of RNA stress granule formation, as well as autophagic degradation regulation. And so these different genetic syndromes may benefit from similar diagnostic and treatment strategies. Genetic testing for MSP should be considered in patients with personal or family history or of one or more of the described phenotypes, including myopathy and PDB. So if a patient only has myopathy, but they have a family member with FTD or another family member with ALS, then one should think about VCP testing. Single gene testing is recommended for patients who have a known familial mutation. So if it's known that it's HNRNP1, A1, then you should test for that. But if patients are undifferentiated and it's not known what gene mutation is at play here, then a multi-gene panel is the recommended type of panel. If patients had genetic testing in the past, then the doctor should confirm that VCP or the other genes were included in that panel because they may not have been in previous years. We recommend genetic counseling before and following pre-symptomatic genetic testing due to all of the psychosocial implications that can be involved. Myopathy comprises the most common aspect of VCP MSP at 90% of all patients who have the myopathy. The myopathy is characterized mostly by a proximal weakness, although there have been other forms, such as with distal or asymmetric weakness, which may resemble things like FSHD. And these two different patients we have here, they both have VCP MSP. The one on the left, you can see that he has atrophy of his deltoid muscle, the pectoralis muscle, the forearms, and you can see some scapular winging in both patients. And on the right, you can see it's asymmetric winging, worse on his left than right shoulders. For the diagnosis, the clinical exam, of course, is important. CK can be mildly elevated or normal. An EMG may show myopathic features, but may also show some mixed neurogenic features, especially if there's concomitant neuropathy or motor neuron disease. A muscle MRI can actually show what we call fat pockets, where there's a collection of fat with normal muscle tissue around it due to fatty atrophy of the muscle, and that can be seen in the lower limbs. A muscle biopsy can show rimmed vacuoles, fiber size variation, ubiquitin and TDP43 inclusions, although these are not necessarily specific to VCP and can be seen in other types of IBM, for example. It may be helpful in cases of diagnostic uncertainty if the genetic diagnosis has not yet been established. There is no disease-modifying therapy for the myopathy components. Supportive management is the mainstay of treatment, which includes PT, OT, speech and respiratory therapy as is relevant to the patient, potentially mechanical aids for ambulation, and PT guidance on safe and appropriate exercise. Patients should be followed and undergo surveillance for development of myopathy with a neurologist with manual motor testing every 6 months to a year, or more frequently if weakness progresses more rapidly. Frontotemporal dementia comprises 30% of MSP patients' clinical syndromes. They will have rapidly developing progressive behavioral impairments, especially executive dysfunction, apathy, disinhibition, compulsive behaviors. They may have problems with speech production or fluency of speech, and they may have Parkinsonian features as well. These patients should be assessed with neurological bedside testing, such as the Montreal Cognitive Assessment, the Neuropsychiatric Inventory Questionnaire, or NPIQ, and neuropsychiatric testing as well. A brain MRI would show atrophy of frontal and or temporal lobes, which can help confirm the diagnosis. And one can also do an FTG PET scan, which would show hypometabolism of frontal and or temporal lobes, but is not necessary for the diagnosis. The MRI here at the top, you can see some atrophy of the frontal and the temporal lobes as well. There is no disease-modifying therapy for FTD in the VCP patients, just like in regular non-VCP related FTD. They can benefit from supportive management with avoidance of triggers for any high risk or compulsive behaviors, and their caregivers should be offered support and education as well. Speech language pathology may also be beneficial for these patients, and some patients may benefit from antidepressants or antipsychotics. Surveillance for FTD development can be done with annual neurological assessment with things like the MOCA or neuropsychiatric assessment as is warranted. Paget's disease of the bone is found in 40% of VCP patients. These patients may be asymptomatic and may just have an elevated ALK-Phos level, but they may have bone pain due to the abnormal bone remodeling that happens in Paget's. They may also have bone deformities, pathological fractures, or hearing loss, depending on which bones are involved. This X-ray here shows that the T10 vertebrae is enlarged, dense, due to that abnormal bone remodeling. The most sensitive diagnostic test, though, is a radionuclide bone scan, which can show normal tracer uptake in affected bones. X-rays can just be helpful for focal bone pain. The serum ALK-Phos is less sensitive, but is typically elevated when there's active disease. There's several other biochemical markers that can be tested as well, but there's no clear advantage of them over ALK-Phos. In terms of treatment, bisphosphonates can be helpful for bone pain. And surveillance of bone disease development can be done with a baseline radionuclide bone scan, and it can be rechecked if the patient does develop symptoms of bone pain at a new site. Serum ALK-Phos can also be helpful to do as a screening test every 6 to 12 months. ALS is seen in about 10% of VCP MSP. These patients present with multifocal, usually asymmetric weakness, typically brisk reflexes, atrophy, fasciculations, sometimes bulbar and or respiratory muscle involvement, although those may present later on, and weight loss. The EMG would show a motor neuron disorder. And treatment is typically best served in a multidisciplinary clinic setting with PT, OT, speech and respiratory therapy, and a social worker, similar to IBM. But this would be typically every 3 months would be the ideal time frame for visiting this clinic. There is no consensus from our meeting on whether or not to prescribe the ALS drugs such as riluzole and edaravone. These drugs may provide the same benefit to VCP ALS patients as it does to non-VCP ALS patients, and similarly, same side effect profile. So that can be up to the discretion of the provider and the patient. If patients do develop more rapid progression of weakness, then one should suspect that there could be an ALS phenotype evolving, and that can be evaluated in clinic with a neurologist and with an EMG when this is suspected. CMT, Charcot-Marie-Tooth neuropathy, is really just an isolated cases that has been reported in VCP. They will present with similar features as your other types of Charcot-Marie-Tooth, with a length-dependent weakness, atrophy, and sensory loss. They may have trophic foot changes, as you can see with this high arched pes cavus foot and the hammer toes, and they would have reduced reflexes. An EMG would show an axonal sensory motor peripheral neuropathy, and genetic testing would confirm this. However, it should be noted that it's more likely that a VCP patient has neuropathy from a different secondary cause, such as diabetes, and less likely from a primary CMT. So that should be suspected first. They can benefit from supportive therapies like PT as well, and potentially surgical procedures if there are deformities or contractures. And patients should just have a baseline EMG when they're diagnosed with VCP, but they don't need it to be surveillance for CMT in general because it's so rare. Parkinson's disease occurs in about 4% of patients with VCP, Parkinson's disease or Parkinsonism. This is characterized by hypokinetic movement disorder, bradykinesia, muscle rigidity, rest tremor, and postural instability. A dopamine transporter scan with SPECT would show dopamine deficit in the caudate and putamen. So on the left panel, you can see what normal uptake would be in the caudate and putamen, and on the right, you'll see reduced uptake in a patient with Parkinson's. These patients may benefit from a trial of Sinemet or other dopaminergic agents, and they can be screened with surveillance with a baseline MDS-UPDRS assessment to look for signs of Parkinsonism and to quantify that, and that can be repeated yearly as needed. Cardiomyopathy is reported in just a case series, so it's not as common. These patients may be asymptomatic unless they have more significant heart failure or ventricular involvement, in which case they may have shortness of breath on exertion and other signs of heart failure. Cardiac MRI is the gold standard for diagnosing cardiomyopathy, although the echocardiogram can also be useful for heart structure and function. You can see on the top panel our echo here, and the bottom panel is an MRI, which is much higher definition and easier assessment, especially if patients have any anatomical deformities like kyphosis. So for neuromuscular patients in general, cardiac MRI can be more valuable. Treatment of cardiomyopathy is ACE inhibitors or angiotensin receptor blockers, beta blockers, mineralocorticoid receptor antagonists for cardiac remodeling. If patients are refractory to pharmacotherapies and if they're severe, they may require AICD or LVAD or even heart transplant, but there's very limited data about this in PCP patients. Patients should have a baseline cardiac MRI. It doesn't need to be repeated unless they're abnormal or if they have symptoms that arise. Respiratory dysfunction occurs more frequently in 40 to 50% of patients. They may have recurrent pneumonia, weak cough, aspiration, disordered sleep, breathing, or respiratory failure. They can be screened with pulmonary function tests at baseline, including forced vital capacity, peak cough flow. A serum bicarb is a really quick and easy way to look for renal compensation for chronic CO2 retention. And a sleep study is also helpful for sleep breathing dysfunction. Treatment involves respiratory therapy, cough assist, suction, non-invasive positive pressure ventilation, and patients also should be up to date on their vaccines. Surveillance for respiratory dysfunction includes the tests I already mentioned, and PFTs should be repeated annually unless they're declining more rapidly. In conclusion, VCP-MSP is a very rare disease with diverse and heterogeneous multi-organ phenotypes, and it does need to be better recognized in the physician community. Our international multidisciplinary meeting in April of this year helped to establish the standard of care recommendations for the various aspects of the disease. We do need to develop an optimal clinical outcome assessment, or COA, for the different aspects of the disease for VCP-MSP, and that would help us better monitor and manage these patients, and also help us design future large-scale studies that could help us be better informed on what therapies, exercise programs, or even disease-modifying drugs could be helpful for these patients, and which patients may be better responders than others. Thank you so much to all of our domain working groups. I've listed all of them here. We have our different working group members and team leaders and our senior advisors listed. So thank you so much to everybody. And that's the end of my talk. Thank you very much.
Welcome, everyone. Sorry, I was muted. I'd like to welcome the panel to open up their mics and their cameras. One of the things that was truly remarkable about this project was that most everybody were not from the same clinic. We're from so many different disciplines, and we learned so much by doing this project together. I wanted to kick off this panel with a question for each of you, and we'll start with Dr. Pfeffer. What do you see as the biggest gaps in clinical care for VCP patients?
Yeah, thanks, Allison, for that question. Maybe it's not predictable to hear that. I think the biggest gap is in diagnosis. I believe there are probably still many people who are undiagnosed with this condition, particularly the people who have later onset presentations, milder phenotypes, or have atypical presentations in any way. So I think in many ways, we're in a good position to address this now, given that most people are being sequenced with sequencing panels for all types of different clinical presentations right now. So because of the diversity of presentations with VCP-related disease, I think it's important that VCP should be included in as many relevant sequencing panels as possible, and even some barely relevant, potentially, sequencing panels. So that way it gets picked up. There's a colleague of mine here in Calgary who doesn't want his name attached to the very cynical expression I'm about to make, but he said once in a lecture, genetics is the only field of medicine where you can diagnose a condition you've never heard of before. And I mean, it's incredibly cynical, but it's also incredibly true in the genomics era. And I think that is, this is going to sound terrible, but I think that is what we should be aiming for in genetic diagnosis, so that people who have never even heard of VCP-related disease can still diagnose it because it's present on the panels and can be picked up no matter how atypical or unusual that presentation may be.
Thanks. Dr. Roy, how about you?
Thanks for the question, Alison. I think from the discussion we had today, and it seems fairly clear that one of the major clinical gap in VCP is under recognition of the heterogeneity in the phenotype of the disease. We know that it can present as proximal muscle weakness, but so many patients also can present with distal weakness, foot drop, scapular winging. So if we just focus on one particular pattern of muscle weakness, then we don't capture the real heterogeneity of the disease. And interestingly, even if we do the EMG or nerve conduction studies, they also show a similar heterogeneous pattern. You can find pure myopathic picture, neuropathic picture, and sometimes in many patients, a mixed pattern of both myopathy and neuropathic findings, neurogenic findings. So that eventually leads to delay in the diagnosis, as Jerry was just talking about. So that is one of the major areas. And we also know that some percentage of patients, about 10%, may develop motor neuron disease. So we should also be cognizant about that. And if we find findings on the EMG, which are consistent with motor neuron disease, then we need to monitor this group of patients more frequently to assess progression, and because they can progress much faster. So that would be the two major areas from the neuromuscular standpoint, in my opinion.
Dr. Ghoshal, do you have thoughts on this?
I do. So I get to piggyback on what Gerald and Bhaskar have already said. So as the co-lead for the frontotemporal dementia section. And so we were probably, to some extent, the furthest afield, maybe in terms of the more obvious connection to VCP, which I think is the awareness bit that Bhaskar was just talking about. So you have to be aware of frontotemporal dementia itself. Then in the context of VCP, where it appears, as Manisha said, 30% of the time. So if you don't consider it, you don't ask the questions about it, you don't query, screen, or test for it. And so then those are those delays that lead to the diagnosis, and then let alone the management, right? So there's several steps there that I think this standard of care practice allowed us to enter the arena and say, speak to the frontotemporal dementia piece as part of the whole kind of the phenotypic heterogeneity of VCP. So I think the awareness speaks to our section as well.
Meredith, what are your thoughts as a physiotherapist?
So all of those things, absolutely. The awareness from the general community to actually bring the patients to us in a neuromuscular specialist clinic. But for me, what's really important, and I think the message is quite clear through the previous talks today, Eddie mentioned the need for longitudinal clinical phenotyping was essential. Manisha's mentioned about clinical outcome assessments. Physiotherapists in neuromuscular clinics seeing these patients will utilise clinical outcome assessments of motor function or respiratory testing or upper limb function testing or mobility testing in standardised ways in order to actually document patients' progression. And that will, by doing this globally in a standardised fashion with tools that are actually meaningful to patients with VCP, that will improve our clinical care. We'll have a better understanding. We know the disease is heterogeneous, but we have some tools to actually measure these patients with already. And if we understand the longitudinal change, then we can actually help patient management by being able to predict a loss of ambulation or a loss of function. And that's really important for patients and being able to get on with life. You know, we've seen from some of the data presented over the last 2 days that, you know, we have a significant delay in diagnosis. And then once we do have diagnosis, quite a short time to actually impact and provide care. So providing a multidisciplinary clinic access and timely referral to occupational therapy, early discussions around mobility aids, because those are quite difficult discussions to have and they take time. But my big thing would be that we need to utilise particularly standardised clinical outcome assessments in clinic, and actually it's more than manual muscle testing. That's not sufficient to monitor VCP. It needs to be motor function testing.
So Meredith, at Newcastle, you see a pretty large number of VCP patients comparatively.
As far as VCP goes, yes, we do.
I wanted to know, and when do you prescribe like therapy, and have you seen results, improvement in function based on level of?
So it's not so much, we're not measuring for, we haven't done any specific interventional trials, but within the clinical setting, what we're trying to do is make sure people have access to what they need when they need it, that we utilise exercise in a safe fashion that people actually enjoy doing. There's no point prescribing hydrotherapy if your patient hates the water. We need to be practical and realistic. Obviously there's regional differences around the globe about how things are done. So we manage respiratory until such time as the patient needs non-invasive ventilation. And so there's a lot of work around ongoing monitoring of both lung capacity, but peak cough flow as well, to then instigate respiratory therapy. And that can be really helpful for patients. Things as simple as a lung volume recruitment bag, assisted coughing techniques. And so we're gathering data in a systematic way, but we haven't done an interventional trial as such.
You had a comment in chat about the cardiac MRI and there's regional differences. I was wondering, especially maybe to Dr. Pfeffer, it was mentioned earlier about the diagnostic and the lack of genetic testing, say in Africa, or that we're doing a biopsy, a muscle biopsy might be more useful or more the access, to be able to access it.
Yeah, that's of course a very difficult question to answer because, ideally your standard for diagnosis will be the genetic sequencing. For this condition, there's a lot of overlap between the muscle pathology findings or muscle MRI findings with other conditions. So even if a different test is more available in a particular region, it may not help you in diagnosing this condition unless you really strongly suspect it. In these kinds of situations, it may hopefully be possible to take advantage of sponsored testing programs where the testing can be free of charge or at a markedly reduced cost for the genetic sequencing. But that is otherwise definitely a big challenge that has to be addressed.
Thank you. This is a different question, Dr. Roy. There was mention, I know, the muscle biopsy, and when we were developing this standard of care, there was debate on whether to use a needle muscle MRI or biopsy or a different aspect. Can you speak to that? And I remember there was someone who mentioned it earlier in the conference about preference and. Oh, you're muted, Dr. Roy. Can you?
The problem with the needle biopsy is that sometimes you may not be able to look at the morphology as good as you want. I know there are some debates, and many neuromuscular physicians would argue that needle muscle biopsy is same as the open muscle biopsy. But I'm not going into the controversy. In general, conception is that the open biopsies are better to look at morphology. And for VCP, sometimes we can see the rimmed vacuoles and some other characteristic features. So probably an open biopsy is better. However, the needle biopsy can provide information on some of the molecular aspects. So it can be fine for that, but just to look at the histopathology or the structural changes in the muscle, in my opinion, it's better to have an open biopsy than a needle biopsy.
Thank you. And Dr. Ghoshal, there was talk about Neurosite testing and screening in the clinic and how there's a big gap, or you have to be able to interpret the results and access to a specialist in FTD. Can you speak to that?
Sure. So this came up in our discussions as well as a section about what tools are out there, how accessible they are, how widely used they are and adopted. And that generated a lot of discussion. And what we opted for the standard of care purposes was to offer very simple, straightforward, readily accessible tools like the MoCA and the NPIQ. They're not perfect. They weren't designed for FTD by any means, but there are aspects there that can at least be a hit, right? So it's a screening test. If there's something that flags on one or both of those tests, it would prompt a referral for either formal neuropsych testing, which takes 3.5 hours, and may not be appropriate for a screening venue, and a referral to a specialist at that point in time to make sure that when those results were obtained, that there was an appropriate kind of a summary of what all that meant and how one could then land on a diagnosis and develop, talk about supportive therapies and so forth. So I think when we heard back from reviewers, there was discussion about kind of specificity of testing versus kind of our broader, very general use tools that we chose to go with. The specialty tests are there. They are also regional, as Meredith mentioned. So there's definitely these favorite tools, the ACE among them. But not widely used, kind of niche uses in specialty clinics, and while maybe better for FTD, again not widely used. And we kind of pivoted that if our portal of entry for our patients was through that of a general neurologist. I mean, certainly in a multidisciplinary clinic, as Jerry was mentioning, that would be a bit different. But if we're going to take the vantage point of the general neurologist, and we want some quick general tools at a basic office visit that isn't more than an hour long, if that, could be used.
Thank you. I wanted to, Dr. Pfeffer, you can comment. You don't need to type it.
Sure. Yes, I was just answering Dr. Kimonis's excellent question about sponsored testing. So these kind of come and go. I think a year or two ago, I saw, for example, a program through one of the major genetic testing companies that they were offering free testing for their myopathy panel, and another was offering free testing for a spinal muscular atrophy panel that was actually results from that were later published as well. I think in Frontiers in Neurology. I think I can send people the links for that if they're interested. In Canada, we have a sponsored program for this through a charitable industry partnership. So it's actually very, very easy for us to get a myopathy gene panel done. There's another partnership that allows us to get neuropathy gene panel testing done. Any other testing for the time being, we have to apply through a special process. But a lot of these will be specific to particular jurisdictions. I definitely recognize that I'm sure it's done differently in every single other country. But would be nice to maybe know what the resources are for different countries and increase awareness of this so that people who need testing can get access.
Thank you. And I wanted to comment, Dr. Komonis was one of our senior advisors and on this project. And so if you wanted to go ahead and make your camera, we have about 5 more minutes. But I did want to ask the panel, what's your biggest surprises and lessons learned? Just a little snippet from this project. Dr. Pfeffer.
Yeah, I think it wasn't really a surprise, but more of maybe a partial surprise, partial realization that there is actually quite a lot that we can do for patients. I think the narrative out there is that for rare diseases where we don't currently have a disease-modifying treatment, that there may not be much that we can offer. But getting all of these domain experts together, talking about the different things that we can do to help patients throughout, the diagnostic and treatment journey, really shows that there's value in knowing about this condition, that there's a lot that we can do to help people who are living with this condition. So that's really what inspired me about this work.
Thank you. Dr. Roy?
It's not a surprise. Rather, I would say it was a very nice to see how dedicated physicians and people involved with clinical care throughout the world to try to come forward to build some rare disease. And I think the collegiality we saw and the excitement and enthusiasm for everyone of the whole team, it was very exciting to me. And from the patients, the physical therapist, speech therapist, it was a very exciting project to be working on.
Thank you. Dr. Ghoshal.
Yep. So echo everything has been said. I think we all love what we do, and we were looking for ways to kind of go deep very quickly, and on occasion had to take a step back in terms of thinking about who it was that we were trying to help, not just on the patient end, but on the clinician end as well. So quite a bit of discussion, healthy discussion about calibration, what to do, when to do it, how often. I think those were, I wouldn't even say spirited conversations, but really, really thoughtful conversations about what is kind of an eye to patient burden, how much testing is too much to ask on the annual, is that even meaningful in some of these types of tests that we can offer. So that was really nice discussions. And then just to echo what Jerry was saying, there's been some data now in the FTD space about, regardless of kind of your genetic predisposition to develop disease, that physical activity and cognitive engagement can really alter your trajectory, not from the brain atrophy standpoint, that's happening, but despite that, how well you could continue to do on tests like the MoCA and other kind of standards of care types of measures, if you will. So I think that was a nice point. I think Manisha and I probably talked a little bit more about that it's not the woefulness that there aren't things already in the hopper that are disease modifying, the magic DMT words, but there's really things that you can do on a day-to-day basis to already alter your own trajectory.
Singing from hymn sheet as everybody else, particularly Dr. Ghoshal, around making sure patient burden, but using things that are meaningful. And I think the lesson learned from this very dynamic group that's come together to do the standards of care is that we may have small patient numbers in each centres, but all of those patients are contributing something so critically important to furthering our understanding of the disease, and certainly becoming better at documenting it and reporting it in a standardized way, so it actually has meaning, and it helps us become more clinical trial ready by identifying what's important to patients as the disease changes, and how we best measure them without over measuring and overburdening.
Everyone, I think that really summed it up. Just people coming together, collaborating to try to improve the lives of patients, and that's really why we're all here today. And that's really been your mission as doctors, and I just applaud each of you for what you've done for our community. Now that with that being said, I'd like to end this session. It's officially closed. You can leave and go to the next session. Thank you very much.